We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research. Well, hello, Nikki.
Hey, Jesse. How are you?
I'm good. Are you feeling the heat this summer?
Yes, ma'am. Yes, I'm feeling it. Dripping with sweat as we speak.
Do you have any fun summer plans?
We like to go to northern Michigan to escape all that heat. So we'll do that in a few weeks. So we're looking forward to that.
Oh, that's fun. So speaking of vacations, do you know where bees stay when they're on vacation?
I have no clue.
Well, at an Airbnb, of course.
Oh, I get it. That is cute. Love it.
I mean, I thought so.
That's
but
cute.
Well, let's get back on task with today's guests, Cynthia Lakon and Dr. John Hipp, who are here to chat with us today about their article, Sociospatial Health Disparities in COVID-19 Cases and Deaths in U.S. Skilled Nursing Facilities Over 30 Months. Cynthia Lakon is a professor in the Department of Health, Society, and Behavior at the University of California, Irvine. Cynthia was also the founding and interim chair of the Department of Health, Society, and Behavior at the University of California, Irvine, and she received her doctorate in health behavior and health education at the University of North Carolina at Chapel Hill Gillings School of Public Health. Her major research interests include social networks, adolescent substance use, the health of elderly populations, and ecological models of health behavior. Her work has been published in journals including Social Science and Medicine, American Journal of Public Health, American Journal of Infection Control, Journal of Association of Nurses in AIDS Care, Health and Place, Tobacco Control and Prevention Science. Welcome, Cynthia. Happy to have you today.
Hello.
Yeah.
Oh, very happy to be here. Thank you so much.
Fantastic. And Dr. John Hipp is a professor in the departments of Criminology, Law and Society, and Sociology at the University of California, Irvine. His research interests focus on how neighborhoods change over time, how that change both affects and is affected by neighborhood crime, and the role networks and institutions play in that change. He approaches these questions using quantitative methods as well as social network analysis. Welcome, Dr. Hipp. We're very excited to have you here as well.
Thank you so much. Lovely to be here.
Awesome.
I do want to say it's very exciting to have you guys on here because the nature of your studies with, health, society, behavior, criminology, law, sociology, very interesting. And we don't normally get the opportunity to talk to people in your field.
Yeah.
So we're very excited to have you guys on.
So, Cynthia, do you want to kick us off today by telling us why it is important to study the areas around nursing homes and not just the nursing homes themselves?
Yeah, absolutely. This is a really important question. It actually started with a very personal experience of being in a nursing home with my dad, who was at the end of his life, and thinking about how does the area around the nursing home that he's in versus the area around the nursing homes that are in other more disadvantaged areas, how does that affect the safety, really, and the patient experience of the residents and of the staff and the facility personnel? So that's sort of how this idea germinated. And really the vulnerability of elderly populations who are housed in these nursing facilities, their potential for transmission for something like COVID-19 or perhaps other respiratory viruses as well, is likely very impacted by the social conditions in the geographic areas surrounding the facilities. We define these factors as socio-spatial disparities. They're place-based, racial, ethnic, socioeconomic disparities in health status that disproportionately disproportionately can be experienced by low-income and minority populations. This idea is also premised upon a long-standing and robust epidemiological evidence indicating a social gradient in health. And based on this notion, we posited our study that skilled nursing facilities located in more impoverished, disadvantaged areas that also had higher proportions of minority populations, and coupled with things like residential segregation by race, ethnicity, and socioeconomic status, will actually display relatively higher rates of COVID-19 cases among resident staff and facility personnel. We know from studies that social disparities in COVID-19 transmission have manifested in numerous ways around the United States. We saw surging infection rates in lower income neighborhoods with high proportions of minority residents, including African Americans, Latinos, other immigrants, and folks with Native American backgrounds, bearing a disproportionate burden of this pandemic. Such communities face impacts due to residential segregation and other effects due to income inequality, which have actually exacerbated disease transmission in these communities. There are likely social and economic factors of the geographic area around a nursing home which affect the likelihood of patients being exposed and having transmission of COVID-19 and other respiratory viruses. The prevalence and incidence of COVID in a community locale in which nursing homes are situated affects the level of transmission within facilities. Other factors include, but are not limited to, perhaps the funding a nursing home has, which can then affect the number of nurses staffing the nursing home, the PPE that's available, staff time devoted to things like infection control, having appropriate engineering controls like ventilation systems, and as well the percent of staff and residents vaccinated and policies regarding that. All of this may be more likely to be better achieved in a nursing home that's relatively well funded and is perhaps as a result also likely located or incidentally located in a geographical area that's economically vibrant versus a disadvantaged area and financially distressed facility. As in the latter context, that nursing home may be more, or those types of nursing homes may be more likely to encounter difficulties that can then translate into more risks for the safety of their resident staff and personnel due to lacking in the aforementioned resources. So that's kind of in the nutshell.
Yeah, wow.
Yeah.
That is a lot, yes. And that's not something that we typically consider and think of. And there's a lot of variables that go into that. So next, tell us a little more about how the geographic areas surrounding the skilled nursing facilities were defined and measured for that socio-spatial context. Dr. Hipp, you can take that one, yeah.
Yeah, well, just to answer that, because this is, I study neighborhoods and that sort of thing. So this is kind of what I brought to the project in a lot of ways is how do we measure this? And you might use just a census unit, which is a census tract, but those can be off a line from where these are located. So what we did is we used where the facility was located, and we drew a buffer around it, say about a half-mile buffer. You could do different distances sort of thing, but we went with that. And we measured it that way with the idea being that this is a more accurate context of what goes on. And what do we think matters in that context is kind of what Cynthia was talking about, whether it's where the workers come from, where visitors come from, where the patients come from. All these things are all part of that. And so that's how we measured it based on this buffer. And we felt that this would capture a more accurate characterizing of the environment that these institutions are located in.
How do the number of beds in a nursing home affect the number of COVID-19 cases?
That's, in part that's, it's an exposure variable, if you will. The more beds, the more potential patients there are to get sick. But it's also important in that what we were interested in, like a larger sized institution versus a smaller size. And there's debates about what that might be. In a larger size, maybe you have better economies of scale and therefore, more efficient in, doing these various infection control procedures. Or else, conversely, maybe it's in a smaller location that there's, fewer people and fewer possible exposures, and it might operate that way. What was kind of interesting for us is we found a split, and this is something we're going to talk about more, but there was a split between what we saw in the first 6-8 months or so in the pandemic versus after that. And this was one instance where in the first 6 months or so, it was larger facilities that were proportionally experiencing more cases. So the larger, so it was, whether that was a larger exposure thing or whatever, that's what we were seeing. Whereas after the first 6 months or so after that, larger facilities were actually doing better in our analyses. It was the smaller facilities that, per capita, if you will, were experiencing more cases, more deaths, sort of thing. So that was an interesting change we saw over time.
Dr. Hipp, can you also tell us what the primary data sources used in the study were and how were these data integrated?
Yeah, that's a good question. So we used several different sources. One, we got information on COVID-19 cases from the Nursing Home COVID-19 Public File. This was data reported by nursing facilities to the CDC's National Healthcare Safety Network system. This has weekly data that gets reported, and their cumulative cases is how they report the data. We use data from the end of each month. We did in some of the analyses, we were doing monthly things of these cumulative cases, trying to show this change, because one of the things we found was this big difference, and so we were trying to see when did this change occur. So we were using the monthly data from that. But then another very important data set we had is this really nice data set, the LTC Focus data set from Brown University that they make publicly available. It provided the latitude and longitude of these locations, which is important in a moment I'll talk about. It also provided demographic information on the residents as well as the staff and facility personnel, and that's how we created some of the measures of that. But then with those latitude longitudes, we can then place those into census blocks, which is what we use because we wanted a really small unit, because then we were going to construct a buffer around each of those blocks. And then we can merge, based on the block, we can merge in our data on the buffers around them, which were constructed based on U.S. Census data as well as American Community Survey 5-year estimates, that we created the buffers and then merged in based on the block. So several different data sources that we were able to combine together to explore these different questions we did.
And what were the dependent variables in the study and how did you measure those?
Yeah, that's an important point. That first of all, from the data, we had cumulative number of, first it was reported laboratory positive COVID-19 cases. Again, these were reported to the CDC by the facility. And so we had this data up to the particular time point, both for residents as well as staff and facility personnel. So we've got this cumulative count, and for some of the analyses where we do later, we did the first 6 months, of course, is cumulative, but then you say, well, the next 6 months, obviously, we're subtracting the cumulative after 12 months or subtracting the 6 months from the 12 months to get that change over that time period. So we did that for both residents and facility personnel, but then also we had a cumulative count of deaths among residents, which we also were looking at as well. There was deaths among staff and facility personnel, but happily there was too few for statistical analyses of those. But that's what we used as our dependent variable measures.
Interesting.
Dr. Lakon, what were the primary factors contributing to the disproportionate vulnerability of the elderly residents in long-term care facilities to respiratory illnesses, including COVID-19? Dr. Lakon, you want to take that?
Sure. Yeah, there are likely many, many factors and reasons for the unique, fragility of this population for transmission of respiratory diseases, notably COVID-19. A couple really notable ones include advanced age, multiple concurrent underlying health conditions, exposure to staff and personnel that might work in multiple facilities, bringing in, various germs from various facilities, staff to patient ratios, nursing shortages, the lack of proper infection control, PPE, and enforcement of that, and just the learning curve too, and that's involved in all of that. And also what percent of people, including staff, other personnel, and residents have up-to-date vaccinations.
How do sociospatial health disparities in the areas surrounding those skilled nursing facilities impact COVID-19 transmission within the facilities?
Yes, so we didn't measure specifically those mechanisms through which sociospatial health disparities might impact transmission within the facilities in our study. However, we did, list this as a very important implication for future research, and this is something we want to investigate in follow-up studies. But what we think is going on is that we think these disparities can affect transmission within skilled nursing facilities really through a socio and economic effect, where in some neighborhoods that are lower income, the nursing homes may be economically strained, experiencing nursing shortages, have a higher staff-to-patient ratio, and lower vaccination rates for staff, other personnel, and residents, fewer PPE resources, fewer engineering controls for increasing ventilation, less room for social distancing. And I know that there are, potentially very negative impacts of isolating seniors, including cognitive and mood changes and things like that. So this is probably quite a conundrum in some of the nursing home facilities, and some may just not have the room to do these things. And perhaps in these more depressed, stressed, skilled nursing facilities, through this socioeconomic effect, there's less time for things like staff time for disinfection and staff time for making sure everyone is vaccinated or making sure that's all followed.
A lot of stuff, kind of what we covered earlier. That's so interesting.
Yeah, definitely. And Dr. Hipp, based on this research, what specific social conditions in the geographic areas surrounding the skilled nursing facilities did you think were the most influential on affecting COVID-19 transmission rates within those skilled nursing facilities?
Yeah, that's a good question. And again, it comes back to this point, that one of the things we really highlighted in the paper was this difference that we observed. We observed one set of effects in the first 6 months, and then it just changed very dramatically after that and remained different after that. So there's kind of two answers to give to that. So if you're asking, in the early part of the pandemic, what we found was that neighborhoods with a higher percent Latino nearby, certainly those facilities experienced more cases and more deaths. Also, neighborhoods with more racial ethnic heterogeneity experienced more cases. We saw some evidence as well that neighborhoods with more percent Black or more percent immigrants experienced more cases. But again, for all of those instances, that was about the first 6 months or so. After that, there was very little effect from those measures. We did see throughout that it seemed like neighborhoods with more percent Latinos had somewhat more cases, but not much other than that. So those racial disparities, very important in the first 6 months or so, then faded away and just didn't come back after that. One other thing I'll mention is that sort of peculiar finding we had that we didn't quite know what to make of is that there's different explanations you might give, but in the first 6 months or so, it was in facilities that are in neighborhoods with higher income that experienced more cases, which is sort of, you could tell stories of why that might be, and there's been some work in the literature that has pointed to why that might be. Maybe neighborhoods like that are doing more traveling or something, so there's more exposures in the very early stages. But then after that, beyond that, then it was flipped around, and it was neighborhoods or facilities in more disadvantaged neighborhoods that had more cases and more deaths throughout the remainder of the pandemic.
Interesting.
Yeah. And so how do you think that the racial, ethnic, and the socioeconomic composition of the residents and their surrounding communities impacted the COVID-19 cases and the deaths within those facilities? You mentioned racial a little bit previously, but what are your thoughts on how that affected the deaths as well?
Yeah, that's a challenging question. Part of it, on that previous question, like I said, I was talking about the neighborhoods themselves. I neglected to mention that there was also similar patterns for the residents within those facilities, and that was something else we saw in the first 6 months or so, that facilities with a higher percent Black or percent Latino within the facilities experienced more cases, they experienced more deaths, in addition to those neighborhood effects. And as to why that might be, again, for us, we would have to be speculating why it might be. Some of that certainly would go back to the point Cynthia was raising earlier, that the sort of disadvantage for these communities and various processes that go on for them might be why we experienced that. But again, it's interesting to note that that was only for the first 6 months, and then after that, a lot of those effects went away, which was something we found particularly interesting.
Mm-hmm. It is really interesting. And I'm going to toss the ball over to Cynthia now and ask if there's any indication as to why there were more Black and Latino residents experiencing higher rates of COVID-19 cases and deaths in that first 6 months. Was there any indication as to why?
Not exactly sure, but in general, Blacks and Hispanics have been disproportionately affected by COVID-19. This highlights the systemic and structural inequalities that they face, social, economic, and political, structural racism experienced by these racial minority groups. Given this disproportionate disadvantage among these communities, such facilities with more Black and Latino residents may have had more economic stress with all the different factors I've sort of talked about in the various different questions we've talked about today. So nursing homes with a higher percentage of Medicaid and racial and ethnic minority residents, studies have found, tend to have fewer resources, financial and clinical, which often leads to reduced quality and safety outcomes. So these are some possible factors.
Yeah, that makes sense.
Well, but let's talk about how the initial, you've mentioned infection control practices. So how did the initial lack of proper infection control measures and PPE in skilled nursing facilities contribute to that spread of COVID-19?
Yeah, so various studies have been done on this issue to date, and nursing homes reported a severe shortage of PPE, especially in the beginning of the pandemic, May to July 2020. Rates of PPE shortages did not meaningfully improve in that time period. Facilities with COVID-19 cases among residents and staff, as well as those serving more Medicaid recipients and those with lower quality scores, were more likely to report shortages. There was a need for policies aimed at providing resources to obtain additional PPE for these very vulnerable nursing homes, particularly those in areas with rising community COVID case rates, were needed to reduce the national COVID-19 death toll burden. A study by the APIC COVID-19 task force indicated that many U.S. healthcare facilities had very low amounts of PPE, hand hygiene products, disinfection supplies early on in the pandemic, and this led to occupational exposures and illnesses, as well as healthcare-associated transmission of COVID-19 and other diseases. Other work indicated that N95 mask shortages were associated with increased odds of at least one COVID-19 case, hospitalization, and as well larger numbers of hospitalizations overall. Adequate staffing and PPE, along with reduced occupancy in smaller facilities, could mitigate that incidence and magnitude. So these are all things that sort of happened earlier on that really affected COVID-19 cases. And our findings likely speak to this initial lack of the shortages in these areas, because our findings speak to the dire consequences that played out initially in nursing homes, likely due to that lack of proper infection control measures and personal protective equipment, because we did see strong sociospatial disparities in the COVID burden among patients, staff, and other personnel members in the first 6 months of the pandemic. And we were so happy to see that all of this changed in our study. And although we didn't measure it explicitly, or we didn't measure it, we would likely attribute it to the fact that there was learning and more implementation and more funding for these infection control measures.
That's a great point, because I want to talk, if you don't mind, to expand a little more on how the implementation of infection control procedures and vaccination efforts affect that COVID-19 transmission and death rates in skilled nursing facilities over time.
Yeah, so studies show strong support for widespread surveillance, early identification response, and rigorous infection prevention and control measures. Studies suggest that widespread adoption of infection prevention and control measures and the supply and use of personal protective equipment resulted in significant decreases in nursing home infections and deaths. The successful rollout of the primary vaccination resulted in sharp decreases in morbidity and mortality from COVID-19 in nursing homes. Evidence has suggested that vaccine efficacy can wane over time, as we know now, and the use of additional vaccine boosters has been very, very important to restore protection afforded by primary vaccinations. Ongoing monitoring of vaccine efficacy in terms of infection, morbidity, mortality is crucial in this very vulnerable group in informing COVID-19 vaccine boosting strategies, and how important it is to really create policy in the whole arena of nursing homes by state around vaccines. And I'd like to turn this over to John, who can specify a little bit more about our vaccine results and what we found.
Yeah, it's a good point. Like Cynthia said, it was interesting. We found this big change after the first 6 months, and a lot of these disparities kind of disappeared. And then the question was, why was that? And one possibility is it was the vaccines, but in fact, it couldn't be the vaccines because we saw the disparities had basically evaporated by the time the vaccines came out in January. So in that case, it seemed like it might have to do with these various infection control procedures were doing it. That said, we still found pretty strong effects for the vaccines, which we incorporated into the analyses after they became available. One thing is we noted that there was a consistent negative relation between the percent residents vaccinated and resident cases. But it's important to note that it was a nonlinear negative relationship. That is to say that as the percent vaccinated goes up, the rates start to drop. But as you get a higher and higher percentage, the rates start dropping particularly quickly. And so that was particularly interesting that we found that. With staff vaccinated, we also found a negative relationship with resident cases. So again, higher vaccination rates, especially when you got high vaccination rates among staff, you had fewer resident cases. We also found a very consistent negative relationship between the percent residents vaccinated and resident deaths. So again, protective in that way. We also found that the percent of staff vaccinated had a negative relationship with staff cases, but again, only at these high vaccination levels. So again, kind of an interesting thing, not just a linear effect, but it seemed like you needed higher rates among the staff to get this effect. One odd finding we had, and this is one we were sort of puzzled at, is that we found there was actually a positive relationship between the percent residents vaccinated and staff cases. That is, the more residents vaccinated, more staff experience cases. Why that is, we don't know. One guess, maybe there's a complacency effect, but we don't know. But all the others were very consistent with what we would have expected, the efficacy of vaccines.
I just want to note that I think that nonlinearity in our findings is so important because that can offer insight into kind of what is the percent needed in the nursing home. What's the compositional effect, the percent needed to be vaccinated? So you get more bang for your buck. You get what's called a nonlinear, not an additive effect, but a multiplicative effect of protection for people in the nursing home. So that I think that's a very important finding for potentially considering informing policy regarding what percentage of people, what percentage of staff, what percentage of residents need to be vaccinated so that you can get this higher level, multiplicatively higher level of protection.
It's so interesting. Definitely one of those surprising findings. And I know we've talked about Medicaid, you've mentioned that a couple of times. And Dr. Hipp, I was hoping that you could tell us how the presence of Medicaid residents, representing economic disadvantage, how that correlates with higher COVID-19 cases and deaths in skilled nursing facilities.
Yeah, it was interesting that we saw some effects for that, but not as strong as we might have expected going in. We did find a positive relationship between Medicaid residents and resident cases. but it was actually negative for staff cases. But why that might be, we can't even speak to. But again, that was more in just the early stages of the pandemic that we observed that. It was, as an aside, it was interesting that we found actually a stronger positive relationship for Medicare, which is more age-based, which might have to do with that, but not, income-based, both for resident cases and deaths. But again, interesting that our effects weren't super strong for Medicaid participants themselves. And again, that may speak to some of the infection control that Cynthia was referring to, because what effects we did see seemed to go away after the first 6 months or so.
Yeah.
Wow. So, Dr. Hipp, also, what role did residential segregation and income inequality play in the higher COVID-19 cases and death rates observed in those facilities located in the lower income and minority neighborhoods?
Yeah, that's an interesting question. That gets into some of the work I do more generally, which is I'm interested in spatial scale of things. And when you start talking about segregation, you're talking about a larger spatial scale, because you're talking about, where people are clustered within a particular city or county or something like that. And to be clear, we did not measure that. We were just focused on the neighborhoods themselves, and we were looking at what the racial composition of those neighborhoods were. So we weren't measuring, does that occur in this larger segregated environment? So we didn't test that. Now, one thing I will mention, I mentioned earlier on that racial ethnic heterogeneity, which is more mixing in the neighborhood, had some negative consequences early on. So that's opposite of segregation, right? Segregation wouldn't see that. So for whatever, reasons, we did not find that segregation itself matters. But again, segregation is this larger scale thing. But when we looked at the neighborhoods themselves, certainly in the first 6 months, that composition of the neighborhood, whether it was the income or the racial composition, mattered, less so over time.
That's really interesting. And Dr. Lakon, what do the study's findings mean for improving the safety of nursing home residents during the pandemic? What were your findings that would lead you to think that in the future we could have safer policies or processes in place?
I think one really important finding of our study is some insight into, like I mentioned just briefly a minute ago, into what is the percent vaccinated needed for nursing home staff and other personnel and residents to have significant decreases in COVID cases. I think that's an incredibly important thing to think about in the nursing home facility and for the workers and for the residents. Our findings sort of indirectly point to the fact that, those sociospatial disparities, they evaporated, and it's likely, and this is the indirect part because we didn't measure it, of course, but it's likely due to the learning and implementation and funding for the infection control procedures. So future public health initiative and policies and governmental policies could include, based on implications of this study and many other studies, could include increased funding for skilled nursing facilities in disadvantaged areas with high community rates of COVID and other respiratory viruses, have strong, well-specified policies in place for infection control procedures in these facilities, policies for staff and other personnel for their vaccination schedules, testing protocols, availability and proper usage, and education on usage of PPE, social distancing, addressing nursing staffing shortages, educate staff and other facility personnel and residents about why this is all really important to continue in the very high-risk context of these skilled nursing facilities, and to get funding for an implementation and implement engineering controls such as ventilation. And studies like this can indirectly add to the evidence in favor of continued mask wearing, social distancing, disinfection, ventilation controls, all of those things to justify more funding and educational efforts for all of this into the future. When we are going to, of course, encounter new emerging respiratory viruses and other emerging pathogens, and we should use all of this information that we've learned thus far that can be really important for educating people for why this is incredibly important to continue.
Yeah, I think this article really highlights how various factors like staff ratios and facility size can really influence infection rates, and how, we have a societal responsibility to protect those most vulnerable populations, and we need those systemic improvements in long-term care settings. So how do you feel that future public health policies and interventions can be tailored to address those sociospatial health disparities impacting skilled nursing facilities during pandemics? And how can nursing homes use your findings to improve those infection control practices? I know you kind of touched on them.
Basically, because unfortunately, we didn't have the data to specifically test, did mask wearing help? Did availability of PPE help, and all those things? But what is a really strong finding is that we didn't see those sociospatial differences anymore after that 6-month period, which is amazing. That's incredible. That
right.
you don't see, this is a study of it's a national study. We've got a really strong sample, and what we usually see, so sadly, is that we see these disparities falling out across economic lines, across racial, ethnic, economic lines. And it's so bad. And it was so encouraging to see that, wow, after 6 months, those disparities just evaporate. That's amazing. In such a big sample like we had, such a we have a heterogeneity of this sample is really amazing and really strong, which to me makes this study all the more important, the type of sample we have. And so to see this social gradient disappear in a sample as heterogeneous as large and nationwide, representing nursing homes of all types, that's a powerful finding, in my opinion. And that right there should be something that the public health community, infection control community, all of those communities can look to and say, wait a minute, something really important happened nationwide in this very heterogeneous sample. And what can we learn from that? 6 months in, something really terrific happened. We learned how to do infection control in the most advantaged nursing home and the most disadvantaged nursing home. And guess what? 6 months in, there aren't any differences really. So in those case burdens. So that right there is a very important finding. We need to learn from that. Like, how do we continue that so that we can get rid of those disparities in these nursing home facilities? And then, of course, the sort of the secondary implications, although unfortunately we're unable to measure them specifically, are that increased funding, increased PP for all of the things. All those measures are so important. That's what follows from that initial very important result, that those differences evaporated.
Well, we want to thank you both so much for taking the time to join us today.
Thank you.
We both agreed that this has been one of the most interesting COVID-19 studies that we have had the opportunity to read and discuss. And so thanks so much for the work on this. This is really, really interesting. Are there any key points that either of you want to leave our listeners with today?
I just hope that we can continue to think of how do we get rid of these disparities in nursing home facilities for these patients who are voiceless populations, who are some of them are very disadvantaged, and none of them really have the ability to voice their concerns. So I think that was the initial reason that got me thinking about doing this study, and the initial rationale, motivation for it. And so I think as we move forward, and I think that there's just such a need to educate the staff, the facility personnel, and the residents and their families as to why this is all very important. And there are other caregivers in the facility that really they're not specifically employed by the facilities. So they're just sort of in the middle there, and they're not getting the education they need as well to keep themselves and their patients as safe as they could. And so I think all of these are really important moments, teachable moments, really important ones for now and continuing on in COVID-19 now and into the future, and for the the next pandemic and emerging pathogens that will come in our future.
Fantastic. Thank you.
Mm-hmm.
Thank you.
Yeah, this was really interesting, a very, very interesting read. Like I said, we don't usually get professors in your area to come talk to us, so that this was a lot of fun and very educational for us. So
We appreciated it. Thank you.
yeah,
This
absolutely.
was really a pleasure and an honor. Thank you so much for having us.
Absolutely. We look forward to reading more of your work.
Thank you. We look forward to contributing.
Thank you for joining us today. We are Nikki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Althen and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.